I have a speaker that's talked about the big picture. I have a speaker that's talked about the nuts and bolts of does this thing work and validate it. And now I have a great speaker from Colorado Springs, Dr. Stephen Dewey. And the name of his talk is The Dysfunctional Lens Patient. I love this guy. I hope you give him a big welcome. And here's Dr. Dewey.
Let's talk about this 48-year-old male who presented with visual complaints in his left eye with a near planar refraction. I mean, that's pretty good refraction. I pushed the wrong button, sorry, Ray. So, you know, this guy had a cataract evaluation, no cataract, okay? Went to my retina consultant, nothing absolutely wrong, completely normal eye. And so what do we do now? Well, we go ahead and we get the eye trace, and this is a very, very impressive little situation because the cornea looks really pretty good, but we look up here and we've got some internal astigmatism, we've got coma. Interesting. And then we look at the dysfunctional index and wow, you know, all of a sudden what appears to be a really clear lens is actually causing this incredible amount of blur. And after surgery, look at the correction there. So the cornea, fortunately, we even made it a little better with cataract surgery. I bet we used tears on that. But with the ZC-BOO in the eye, it was absolutely fantastic. So to me, the eye trace is the one piece of equipment that you absolutely don't need until you buy it, and then you will never get rid of it because it is so valuable. And so poor lens performance is more than just a simple opacity and grading. Every patient deserves the best vision possible. I think we're all firm believers in that. Sometimes their complaints are real, and the funny thing is this was my eye. Okay. So honestly, I went through a cataract evaluation and it wasn't spotted. And I'm just like, really? Nothing. Okay, so I started using tears. I started thinking, okay, well, it's just a little lubrication. Started thinking maybe I've got early keratoconus. So I actually walked around the floor. And it wasn't until the 2009 Barcelona meeting that I bumped into Carl. And I go to the iTrace booth, and I'm looking at everything. I've had the Pentacam done. I've done everything you can find on the floor. And Carl looks at it, and he goes, I think you have a cataract. And I'm like, now I've had a cataract evaluation. I've had a retina doctor look at me. And I'm looking at this guy who's basically selling a thing at a booth, and he says, I think you have a cataract. And I'm just like, really? You're kidding, right? And so I really didn't believe him until the next meeting when it got worse. And yes, I went and I had another scan done, and yes, I was getting worse. And at that point in time, I believed it was a cataract, so I went back to the same guy, and he goes, oh yeah, you've got a cataract. It's like, oh, good. So the machine found it well before it was clinically visible. And yet, symptomatically, I was fine. Now, look at this opacity map. Where is my opacity? There isn't an opacity. But the amazing thing about the coma that was induced, now, the history I have, somewhere as a wimpy second grader, I was playing at a snowball fight at where they were building a house, and a kid across the big pit put a rock in a snowball and clobbered, and I did not remember which eye it was. I think I know now. But the thing that really amazed me was my refraction. And it's amazing how the Tracy will show the subjective complaint, because mine was distinctly related to bright light. And as it progressed, and I apologize I don't have that scan up here, I became significantly hyperopic at the 2 millimeter pupil. And so it's exactly what people tell you. I can see, but I can't see. I mean, I could tell you the street sign was there. I could not read it. I could tell you there was a license plate on that car. I couldn't give you the numbers. But at the same time, I could not function at that level of vision doing what I do for a profession. So this is a technology that I am absolutely sold on in terms of how it works. And by the way, just finish up the story, Randy Olson took care of this in 2012 out at Moran and put a ZC-BOO in there. And Dan's comments about the presbyopia are just so spot on, it's not even funny. Fortunately, my right eye has still got some accommodative effort. But my left eye, wow, Carl, your tie's crooked. And by the way, you got some spinach right here. But, in terms of seeing up here, nothing. So would I have it done differently? I don't think so. But at the same time, I certainly see the positioning. So what is there about the iTrace that's reliable, that's trustable? I mean, it's an amazing machine. You get good old Placido topography for the anterior surface, which is incredibly accurate. You get this Tracy refraction, which if you've looked at this thing as an amazing machine, just look at it as an autorefractor. It's shocking in terms of how accurate it is if you align it on the visual axis. And the better news is it'll actually grade the value of your refraction for you. I mean, it gives you a green if it's a good refraction, it gives you a yellow if it's kind of and then it gives you a red if it's don't even bother giving them the prescription, you've got some more work to do that day. It separates the cornea and the lens. My word, your talk on that was amazing. Thank you so very much. The software tells me, the software tells you the patient complaint. That's the amazing part. 3 sets of Ks, pick the one you trust, and we'll get into that a little bit. It saves time. I mean, that is really probably the most amazing thing about it. I mean, my technician, Tony, is absolutely the technology geek, and he loves this machine because he knows what's going on with the patient before I do. It saves time, it's objective, it shows what and where the problem is. And it's incredible to show this to the patient because honestly, the thing that really shocked me when Carl showed me this and says, "It is your cataract," is that is exactly what I saw. I mean, I'd been looking at the E on the refraction chart, I'd been spinning the dial, I couldn't get it any better, and that is exactly what I saw. So to have somebody objectively reproduce the image that was coming out of my blurred eye to me was just stunning. So the interesting thing is, as you start getting into some of these cases, you start thinking, oh yeah, I'm going to fix you by taking out your cataract. But this thing is going to save you from doing that because look at how the cornea and the lens are countering each other. So the overall net effect is 0. So you take this out and all of a sudden this becomes manifest. And your patient isn't necessarily going to be too happy unless that cataract is pretty significant. You get 3 sets of keratometric readings. You get your SIM-Ks, of course, very limited there, refractive Ks. But the impressive thing is the wavefront Ks. And this is pretty much very amazing as far as what Tracy can do for you in terms of giving you that anterior corneal surface in a more accurate way than we have before. This is really cool, and this is something that I think we're going to be doing. And again, I've only had the unit for 3 months, but it's calculation of your surgical induced astigmatism. You do the scan preoperatively, you do your surgery, you wait till the postoperative incision is healthy, you do the scan again, you collect 10 of those patients. So I have a question for you. Are we going to be able to do this based upon white to white diameter automatically? Because if you're doing a limbus-based incision...
Right after we put in time travel.
Okay, excellent. Refractive Ks versus SIM-Ks. The SIM-Ks are so very limited in terms of their accuracy. It's an estimation of the old manual keratometry, but boy, the refractive Ks, they can be incredibly different. Look at this. There's an entire diopter shift between the refractive Ks, which I would use in this case, versus the SIM-Ks, which we all used to use. And of course, the dysfunctional lens index. Now, let me show you a clinical example here. Well, is this me again?
No.
Oh, this isn't me. Okay, so this is, oh, thank you. Sorry, it's at the top. I apologize. I got to take a nice ride on the shuttle this morning after United canceled my flight from Colorado Springs to Denver, which involved me sitting in a 14-person van in the very back seat, and that luxurious time in which I was going to be re-reviewing my slides. I got to take a bumpy ride next to a fireman from Pennsylvania. Anyway, this is hyperopic LASIK. Now, this is a really cool feature. This isn't something that's necessarily valid for my practice, but it is. So let's say I'm here today, which I am, and a patient comes screaming into the office and they're having a problem, and they've had LASIK in the past, and they're sure their LASIK is wearing off, and they've just got to have something done, and they need to know about it, and they need to know about it now. They have the iTrace, they send you the scan, and you can reassure Mrs. Jones that it's not her hyperopic LASIK. Her LASIK hasn't worn off. She's got a new problem. It's a cataract, and we'll talk about that at some point in time in the future. The lens opacity map is really an outstanding tool in terms of being able to identify specifically a cataract, again, one that Medicare will pay for. And then, of course, this is another thing where this has really saved my skin. So the patient comes in, 63 years old. They say they've got the cataract. They fill out every single complaint on the chart, and you look at the cataract, and you're like, I'm really not very impressed. And so you're wondering, is there kind of a secondary motive here? And you go ahead and do the eye trace, and all of a sudden you realize, well, I think there is a secondary motive. I think this patient is actually kind of wanting something done, but I'm really not really sure. But at the same time, I can reassure her, her optical pathway is really quite outstanding. And so I was actually able to counsel her, settle her down, and talk to her about other things we can do to help treat her blurred vision. So in any case, thank you so very much for your time. I think it's been a great session. Thank you, Ray. This has been fantastic.